Hi, and welcome back to Module 3, Lecture 2 for Community Health Advocacy and Social Movements. Last lecture, we were talking about screening and preventive programs. Now we'll dive into your reading, which was Daskovich et al., and they did this very large scale and very impressive study about diabetic retinopathy in LA County safety net population. So let's just talk about, first of all, what is diabetic retinopathy, or DR? Well, it's a complication of diabetes where damage to blood vessels of retinal tissue in the eye cause impaired vision, and if untreated, can cause vision loss. It's actually leading cause of blindness among adults of working age in the United States, and DR affects more than 5.3 million Americans. The ethnic majority in Los Angeles County safety net is Latino, and what the authors mean by safety net is uninsured and underinsured patients. The prevalence of diabetic retinopathy among those with diabetes in this group of people is approximately 50%. So half of the diabetics have such an advanced stage of diabetes that they have this complication too. On average, only 60% of patients with diabetes in the United States receive the recommended annual eye examinations in safety net populations. So not just in LA County, but generally uninsured, underinsured, people on Medicaid. These rates have been shown to be less than 25%. And the sad thing is diabetic retinopathy is both preventable and treatable if attended in time. So the gap here that Daskovich et al. Were trying to fill was that in Los Angeles County Department of Health Services, it's the largest safety net in the United States, serving 800,000 people. And it's for uninsured and underinsured patients facing financial and social barriers. The wait times for newly diagnosed diabetic patients in this health system can be as long as 8 months for ophthalmology or optometry, basically specialty care services by eye care specialists. To address this need, Daskovich and her co-authors provided a county-wide TDRS, so teleretinal diabetic retinopathy screening system or screening program. So it's a primary care-based TDRS, and it's very accurate with a sensitivity of greater than 80%, specificity of greater than 90%. So teleretinal diabetic retinopathy screening, TDRS. It's a system where 7 standard field 35 millimeter, what they call fundus photographs, are taken of the patient's eye. So early treatment of diabetic retinopathy study protocol tells how to take these photographs, and then certified readers read the photographs. So these are ophthalmologists or ophthalmologists, optometrists or ophthalmologists. And instead of clinical care standard, which would be a direct ophthalmoscopic examination by an eye care professional. So these certified readers use the standardized validated protocols, including the grade of diabetic retinopathy, so at what level is the patient, recommended timing for follow-up of taking the photo again, which depends. It might be every year, it might be every 6 months, depending on the stage of the issue, and feedback on image quality. So if the photos aren't good, they'll retake them, they'll get retrained. So there's a whole system in place to make sure the images are good so that there's no missing any issues on the photo. So this system that they were testing out increases access by screening through primary care. So as we discussed in your last lecture, access to specialists is more of a bottleneck. So getting this through primary care increases access majorly and moves patients with normal retinal photographs out of the queue for the specialist consult. So the pilot program was 15 of the largest LA County DHS primary care clinics, Department of Health Service, a total of 58 certified medical assistants and licensed vocational nurses were trained and certified as fundus photographers. This created a primary care retinal photography clinic and trained the MAs to upload images to web-based screening software. The process of retraining the MAs was also in place if photographs were unsatisfactory, so that quality control was also there. 10 certified image readers were employed by LA County DHS to read the screening photographs as part of the DHS-wide Teleretinal Reading Center, and referrals for abnormal results were submitted via eConsult, a web-based referral system for specialty care, which allows for submission of screening results and subsequent scheduling of follow-up visits across the LA County DHS based on the result of screening patients, which were then triaged to a specialist. So it's pretty simple, uses some really interesting and great technology. The screening outcomes, so these, I won't get into this too much, but in their pilot program, a total of 21,000 patients underwent the screening for diabetic retinopathy. 68.8% didn't need a referral to an eye care professional because the photos were normal or only mildly non-proliferative DR. Both conditions require annual follow-up. Of the 31.2 patients who did need a referral, almost 20% were referred for DR, as well as clinically significant macular edema, which is the swelling, and 11.6 were referred for other conditions. And so the results of the TDRS in the LA County DHS, by embedding these screening programs in the primary care clinics and using certified medical assistants to take the fundus photographs instead of specialists or even MDs who are primary care physicians. So they did this training of medical assistants and LPNs who could take the pictures and electronically transmit them to a reading center staffed by optometrists. So this retraining of like a shift in skills to a different group of providers, as well as the other measures they took with quality control, improved detection of DR and use of eye specialists by quite a bit, as you'll see, resulting in elimination of the need for more than 14,000 visits to specialty professionals. And what I thought was the most amazing was 89.2% reduction in wait times for screening, and the median time for screening for DR decreased from 158 days to pre-intervention to 17 days after the intervention. So as you can see, screening was highly effective in this pilot program study, and the work of Daskovich et al. Was very amazing because they had done this kind of thing in smaller populations with Indian Health Service or Veterans Administration Hospital or smaller groups, but they had never done this in a catchment area of 800,000 people where it's quite amazing. Even though the group screened was 21,000, but that volume of patient care is obviously unsustainable for highly skilled professionals such as optometrists and even primary care physicians, where there's a huge bottleneck in getting patients in and therefore reduced access. But when they trained medical assistants and LPNs to do some of this work, it was really effective and reduced wait times exponentially and even reduced the need for visits. So it was a great intervention, great example of how screening program can be highly effective in community health, because if you can imagine how much vision loss was prevented in a long-term sense by implementing this photograph-based screening program. So project update 4, it's coming up in module 4, and we'll talk about it then. I've listed out some of the kind of bare bones like overview of the assignment, but I will post the assignment details next module in week 7. So please don't start or choose your partner or anything. I'll give you all the details in week 7. I just wanted to give you a heads up that we'll be doing another website page. You'll be working with a partner who I'll let you know about the process of partnering in week 7. And we'll be doing new topics, and it'll be an interesting project. So looking more at preventive programs, which is what we kind of touched on in this lecture and in week 6. So have a wonderful weekend and rest of your week, and I'll see you in week 7.